Today's expert really needs no introduction, but however, I must inform that she has been breaking gender stereotypes. She's been the former Dean of Armed Forces Medical College, Pune. She has been the Deputy Chief of Integrated Defense Staff under the CDS in New Delhi. And Lieutenant General Kanitkar has been the third woman in the country and the first pediatrician from the armed forces to hold a 3-star rank in the Indian Army. And of course, now she is the Vice Chancellor of Maharashtra University of Health Sciences. So, ma'am, whether it has been COVID-19 or the Ukraine medical student crisis, I clearly remember in several interviews you have said, about finding opportunities in challenges. So if we have to start and roll off this conversation, I really would like to understand, apart from MUHS, which is like now planning to provide online medical education, etc., and, to the war-hit Ukraine students, and even allowing people to appear for the NEET, why has medical education remained so unaffordable in our country? And I would also request the reporters and whoever wants to ask a question to just put in the chat box, so then I'll call out their names. Yes, ma'am.
So firstly, good afternoon to everyone who's joined this session, and thank you for inviting me. It's a pleasure to interact with you all. And I think that's a very good question to start off with, that why has medical education been neglected? I think it answers the question that health as such has been neglected. We had priorities which were, as a nation, which had not put health. I mean, we wanted to get the goals, but look at the budget which was allocated to health. And slowly over time, our health sector public health got quite eroded, and the underbelly was very obvious during the COVID outbreak where we were seeing. But at the same time, look at the resilience and energy with which the nation came together. And today, from probably an underground or this where doomsday was predicted for India, we have come out, can easily say, as winners with our own vaccine, with the largest vaccination strategy. So where there's a will, there's a way. But coming back to your question of medical education, I think it stems from a basic this thing where we subsidized it, definitely, but with competition increasing and demands increasing, the government could not give that medical education at the subsidized rate beyond a limited numbers. With the result, it encouraged and permitted privatization, which is the way forward, because you can't do everything. But that changed from an altruistic and a noble this thing to more of a business model. So I guess that is where things went different. And today students have to go out to do medicine.
So, ma'am, when students are coming back from war-torn Ukraine, what is the kind of strategy that you are looking ahead? What is the roadmap? I mean, you have said that they cannot be included in our system because it would be unfair to the other students. So, what exactly is being planned, and how are you looking at, this?
Yes. So, in that, I think we did sort of Maharashtra really woke up to it quite early. Right at our convocation, which was just happening when these students were coming back, even the Honorable Minister of Medical Education told us, please look at ways and means of how to help them. So we got into action immediately and started collecting data on these students. Now that we have, we've still not got the entire lot. We expect there to be near 2,000-3,000 probably in Maharashtra, because they have a large chunk. But having said that, the only way to reach out to all these students is using what COVID taught us, and that is digital technology. So while some of their universities, we are in touch with the students, and whereas some of the universities have actually started their own online classes. But some universities, which were their state universities, some of them have been damaged and faculty is not there. So they're not able to take on those online classes. So today what we can offer is, and we've already done the homework, and within a week, we hope to have it structured so that from 1st of April, we would probably make online classes teaching material which is curated, which is ready for them to learn at their time and space, including built-in assessments. So that is something we are going to make once they register with us. We would be making the access to all our, because MUHS has already gone online with a digital library. We have tie-up with a firm, Nimbus, which is making on resources available. So we could open those up to the students. And the third thing, I've spoken to all the deans and given them a little time to think whether they can run little workshops for these people on weekends or evenings to give them a little idea of clinical exposure, which in any case, I mean, will be value added. Because when we looked at, I've studied in depth the Ukraine syllabus, as well as interacted with students, their methodology of teaching and curriculum is slightly different. They do more through simulations, and there's not much of direct interaction with patients. So if to that we beef up with some amount of patient-related bedside teaching, it would be value added. And when they come back, whenever they finish their course, they would be able to find it easier to do the foreign medical graduate examination. So we thought we'll be additive. It would also go a long way in giving them a reassurance that people care. And they're at the moment quite traumatized. I've heard stories of how someone walked, I've interacted with students directly. Some of them had to walk long. Some of them saw bombs falling nearby. So they're at the moment quite shaken up. So this would say that, okay, there is someone caring and we can use our time effectively.
Okay, ma'am, several questions are already coming up. So I'm going to ask each reporter to start asking. Partha, please go ahead. Partha?
Hi, ma'am. Good evening. My name is Partha Sarthi. Yeah, I'm here. Can you hear me?
Yes, I can.
Hello.
Yes, I can hear you.
Hi, ma'am. Good evening. I am Partha Sarthi. I have one question for you. We have already, you mentioned about this in your introductory talk. What is the ratio? What is the healthy doctor to population ratio and healthy population to medical college ratio that should we have? And what is it in India? What is the shortfall in the medical colleges that we are facing? Mostly government, because private medical education is pretty costly, as you mentioned. So what would be a healthy doctor to population ratio, and how many medical colleges would we have to build government to fulfill that?
Yeah. So see, we already have, we need a ratio. The WHO has defined that you need about doctor for every 1,000 population, one doctor. And if we look at the way we have added undergraduate seats, like in the last 3-4 years, we've really jumped and we are today having almost 90,000 seats. And if some more probably get added over the next couple of years, which they are doing in, they're opening more government colleges, they're opening at district levels, we should be able to reach this ratio in the next 5 to 10 years, which should not be such a problem. But having said that, I am more worried about, which is a well-known fact. There's no point just adding numbers, because you have 80% population in rural with 20% doctors and 20% population in cities with 80% of doctors. If health has to be equitable, it should not be that you have to live in a big city and have money to take that help. So if that is required, then it requires a joint effort by the health department and the medical education department. Today, the two are at the national level. You have a Ministry of Health and Family Welfare, but at the state level, you have a health department and an education department. And the supply demand is not really judiciously used. So you keep coming across situations that posts are lying vacant, recruitment processes are taking time, the doctors don't want to go there. So I think this is where the problem lies.
Thank you, Partha. Alethea?
Ma'am, just one question. Anuradha, just one question adding to that.
Yeah, go ahead.
No, I think his line is weak.
Ma'am, what is your opinion? Ma'am, what is your opinion about mixology? The government is
There's
trying to
nothing
have
like mixology. There's nothing like mixology. I don't think there's any word like mixology or mixopathy, and government doesn't have that aim. What we need to do is, that's why I didn't add that word, our Indian systems of medicine, we have not let them grow with the equal. If you go down to this, there is, and we've not brought it to the world with evidence-based guidelines or best practice guidelines. And if you conduct a survey just like that, probably a whole lot of us use a lot of them at home as, Dadi ji ke nuske. But do we come out and use them as standard? Somewhere we've developed a superiority, inferiority. But I think whereas there is no place for mixopathy or this thing, there is a definite scope for an integrated approach to wellness. So if you want to look at a patient as a whole, it doesn't matter if you're going to treat just hypertension with drugs, but instead of that, if you add to that a meditation, yoga from here, or a relaxation technique from there, or there are some other dosha, which, after joining here, I'm interacting with a lot of Ayurveda people, and there's a lot of science which is there, which we haven't probably. So I think we need to do research and create integrated best practice guidelines. And we can start with the 10 commonest problems. We're all talking that India is going towards a non-communicable disease outbreak, where hypertension, diabetes, kidney failure is going to rule the roost. And we're going to be the international capital of all this. And if you see an approach, preventive aspect to this, what can one pathy offer? Very little. We can just tell the patient walk. But if we have an integrated approach, I think that can matter. Or when you talk of deliveries, you're talking of painless deliveries and you're using only allopathic. They have techniques of breathing and this thing, or antenatal care. I mean, have we really looked at it and mixed the two together? It's not mixopathy. It is integration. And I think there is a scope for that.
Thank you, ma'am.
That's very true, ma'am. But I also feel that we should also increase the number of seats for our students, because there's too much of competition and very few seats. Okay, Alifia, please go ahead with your question.
Good afternoon, ma'am. My question actually pertains to what Anuradha just referred to. Last week, we had Dr. Nitin Karmarkar, who was the former Vice Chancellor of MUHS, as a guest for the idea exchange. And we had asked him the same question. At that time, he had referred to his efforts to starting a few seats at MUHS. He said that when he took over for almost a year, he realized that this is more or less a examination conducting body. And he said that the MCI guidelines are so stringent that you need a 400-bedded hospital. But there is the civil hospital in Nashik. So they tried to come up with, some kind of a solution where the beds could be shared and seats could be created here. But because of the guidelines, this couldn't be worked around. So how far do you think that the guidelines are responsible for creating this situation? And what is the way around it? Do we need more creative solutions?
We definitely need creative solutions. And I must tell you that Nitin Karmarkar and me, even before I joined, when he said that this was a thought process, I went into action mode, and with military precision, we've already, within 3 weeks of my joining, we analyzed, put up the thing, and we've reached miles ahead already, because we have submitted our application. We've got the government sanction and an MOU signed with the civil hospital. I have already advertised and recruited all the faculty, 70% of which has already joined. And at this moment, as I talk to you, they're busy setting up departments in the civil hospital. So we're going to have a straightaway postgraduate seats being added. And this is the model that needs to be followed. Whereas I agree with you that we have to increase undergraduate seats, but increasing undergraduate seats, it's very, very human resource intensive, because undergraduate teaching needs faculty in your preclinical and paraclinical with an investment. And today that is the bottleneck. So we are jeopardizing quality for quantity. If we keep opening medical colleges in every district, how are we going to teach? So we'll have to make out of the box these things of going online, and one professor, instead of teaching 100, maybe can teach 1,000. His lectures can be made available to everyone, and you have younger, less experienced faculty facilitating the learning process. So that is one way of doing it. The second thing is go in immediately for PG, because today undergraduate teaching is not as, with years and with so much knowledge doubling so fast, the undergraduate 4.5 years is not enough to make them independently able to handle all kinds of emergencies. So if we can give them an integrated and going on into doing equal number of UG, PG, because the competition is tough there also. For 90,000 UG seats, we should have almost equal PG seats so that everyone can get a PG. So that is something, and I think this is a model. It has 3 advantages. The hospital benefits, because all this faculty, 20 specialists that I've recruited will be going and working, the patient care will improve. They will get residents, they will be working hands who will also improve. Every bed then becomes a teaching bed. This hospital is a 500-600 bedded hospital with a huge patient footfall, 7,000 deliveries a year. Look at the scope of learning that can occur. Students need not go to China and Ukraine to learn in simulation labs. They can learn talking to patients. So this is where our strength will be, and this is the future.
That's true, ma'am. And often you have also said, I remember, that a university's soul lies in post-graduation and postdoctoral research. I clearly remember those statements.
Absolute words.
So that's
off the record, I came here, and when I was goading all the team to work, I said, I'm getting the feeling of coming to a ZP office, not a health university.
Well, Ma'am, Sushant Kulkarni, he has a question. He is our defense correspondent, so he may have been interacting with you earlier. Sushant.
Hi, Sushant.
Hi, ma'am. This is so you have seen generations of soldiers and officers in armed forces, and with changing nature of warfare and changing security challenges, the health scenario in armed forces is also changing. There are different challenges which are different than, say, 20, 40 years ago. How is the health and fitness philosophy of armed forces evolving, and what is the way ahead?
No, I think health and fitness, the basic ethos remains that you have to have a fit mind and a fit body. And it is one organization which encourages you, gives you time and infrastructure, and gets you to, make it a way of life. Today, I may be VC here, but 40 years of being in uniform, and I still get up at 6 in the morning and do a 5-kilometer, 6-kilometer trek into the hills of Nashik, which is, it becomes your lifestyle. So I think that has not changed over time. Yes, standards have changed because the weight standards and things. So we are looking at it, and the armed forces is looking at saying that if the whole Indian population average height weight of the Indian standard woman, Indian standard male has changed, do we need to change that? Having said that, I think we're also seeing finally our defense population comes from the same genetic and the ethnic representation of the country. So if the country, you're having increased incidence of non-communicable diseases, we are seeing it, albeit at a little slower rate, because I've done a comparative thing for the late CDS General Rawat, where I showed what is the national average versus our average. Definitely it's lower, but yes, it is increasing at a slow pace because of changing lifestyles, changing food habits.
Ma'am, but just to add to his question, you have headed a defense-oriented institutions, and now you're heading a civilian institution. So obviously the workflow, everything is different. So what is the basic difference that you are looking at?
The basic difference, in fact, my major time is spent in the defense environment was highly disciplined, and everything had an SOP. Everything had certain procedures, protocols. I found those are the new challenges for me. And using the opportunity, we have within these last 3 months created SOPs of HR, SOPs for worker welfare. We've created the accounts code for MUHS, the purchase and this thing committee that has been completed. We're making SOPs for LICs, and this we are computerizing the entire university. So there's huge opportunity, and the difference, whereas on one side here is a freedom. When I have a big canvas, I find I have the liberty to work. I have a support of a huge team, and the government, the governor. I mean, I found a very, very conducive environment. The armed forces being more hierarchical and more rigid, the decision making took longer. I find it faster.
Okay. Ma'am, Amitabh Sinha is the resident editor of Pune, and he would like to ask you a question. Amitabh.
Hi, Amitabh.
Hi, good afternoon. I have 2 questions. I'll ask you one by one. The first one is about the cost of medical education, which Anuradha also asked in the beginning. What is it that makes medical education so expensive? An engineering course, for example, in a private college would cost you 4 to 5 lakh per year even now, whereas a medical education easily would be in the range of 18, 20, 22 lakh per year. So what is intrinsic in the education itself that makes medical education costlier? I'll come to the second question later.
I think the first biggest difference between engineering and this is engineering, you have one set of these things and you can keep repeating the same thing every year. The medical, this thing changes with the patient, this and is patient dependent. So your teaching is, except for the first year, which is totally in classrooms, except for the dissections which occur and a little bit of lab work, subsequently, everything is in a hospital. And if you're using a 400-bedded hospital with that many patients needing, you have to have, there's a huge healthcare cost which comes. And in the government, that is paid for by the government. But in the private sector, when they need to have the patients, they need to make it lucrative for them so that the patients reach there for the students to learn. And they tend to put all that cost onto students.
So if I've understood correctly, so the private medical colleges, part of their hospital costs are actually being passed on to students for medical education, is it?
Yes.
Okay. And my second question was, in the last couple of years, we have seen at least 2 or 3 things which have put the focus back on medical education. One, of course, was COVID, which highlights not just education but also the state of medical infrastructure in the country. So that's one. The returning Ukrainian students, another one, and also the recent
let's
order.
not forget the Chinese students who've come back.
Yeah. Yes.
There are about 18-20,000 of those who are also in India now.
Okay. Also, the fact that the recent order about some of the private 50% of the private medical seats needing to be offered on government rates. So we have seen quite a few things in the last couple of years, which puts the focus on medical education. Also, probably forces us to initiate some sort of reforms in the medical education sector. I wanted to know if what is being considered, what are the 2 or 3 top priority things that are being considered across the country as part of that reform package?
Yeah.
Also, ma'am, to add to Amitabh's question, there is this NEET, the recent lot of orders which are coming up is the upper age limit for the NEET exam.
Yep.
So that has been waived, right? So, what do you think about that? Just in addition to Amitabh's question.
No, I think I'll just take the last question first and then go on to the reforms. Removing age limit, I think it's fair enough. We are going by, international people have done some, and then suddenly there's a calling, I want to do medicine. If he can clear the need, why not? I mean, he can come back to becoming a doctor. So that's one thing. And second thing about the reforms, I think there are a huge number of reforms which are in the pipeline through the NMC, and having been part of the Board of Governors with Dr. Paul when the MCI was dissolved and a Board of Governors was constituted, we were looking at increasing the number of seats. So in the last 3 years, using different permutations, combinations, and giving additional seats, doubling up in some places, changing, the new MSR has come up, which is, and the TEQs, which require lesser space, lesser number of faculty to be able to teach, so that you're using more use of technology, so that it's less human resource dependent. But having said that, you can't do that in medicine. That is the reason why we are sort of constrained with that. We need to concentrate on developing and getting people more into being able to teach. So therefore, this academic career in medicine has to be made more lucrative. The second reform that is being looked at is sort of like, see, there was AIIMS, which was just one in Delhi, and now there are suddenly AIIMS, but everywhere again, there, or like Maharashtra has one in Nagpur. The constraints are in faculty. Finally, you don't get the faculty because medical education is being changed into a competency-based education. From 2019, the batches which have joined are competency-based medical education, which is very resource-heavy on teachers. And that is something we have to find solutions to, because you can't just have quantity. Health is one thing, you need quality. So I think that is a very, very biggest challenge that we need to, as to how to improve quality rather than just taking on quantity. Then the another interesting reform that has come in is the district residency program. This was started with two things in mind. That is to take, so that district hospitals, the patient care will improve. If there's shortage of doctors, if you have all your postgraduates from the medical college spending by rotation 3 months over there, then it has two advantages. The students learn what is happening in community, because we have to make them available for treating people in the community and sensitize them to the needs of the community, rather than just having tertiary care and very, exam-oriented difficult cases to learn about. So I think that is important. And secondly, over time, if we find this district residency program works, when they are away, you can fill that up with, in the same infrastructure, you could probably take a 30% more postgraduates. So this is another reform which is being looked at. The third reform that is being looked at is how to make every hospital bed a teaching bed. And in that, I will tell you something that in my last chat with the Ukraine and Chinese students, I told them, while we can help you with this, why don't you use your time to, there are nursing homes, there are hospitals. You could just do a apprenticeship by hanging around with doctors, seeing how they are treating, helping with, maybe taking the blood pressure, taking height, weight, and you would be learning so much while looking at things, so that is also something. So how to do that in a more organized, like the national board, DNB, initially was sort of dithering and, wavering, but today all your private hospitals have DNB seats, which has doubled up the available postgraduate seats. So that these are ways that we can increase our scope of learning.
Thank you, ma'am. Ma'am, I have so many questions coming up. I have my colleagues from...
Anuradha, I'll just ask a follow-up question on this.
Okay,
So, on the cost of medical education thing, I'm just coming back again. Mainly, so when you say, the medical colleges, the hospital infrastructure actually puts some amount of load on medical education. I'm just trying to understand, why should that be so, and can it be brought down? I mean, say if we see private hospitals, independent hospitals without a medical college, they are able to recover their costs. So why?
1 minute. I mean, Amitabh, I'll stop you there. They are recovering their cost, and who's paying for it?
The patients, of course.
Patients.
Yes.
Exactly. But where those corporate patients don't have 20, 30 students coming and examining them to learn on them, right?
Right.
They are the corporate hospitals, and that is a business model which is also leading to a lot of dissatisfaction among a lot of patients.
Yes.
And
Yes.
all your consumer court and ethics boards are all mostly with the corporate hospitals.
No, so I'm wondering, would the cost of medical care therefore be lower in the hospitals that are attached to medical colleges?
Yes, definitely it's lower. It would definitely be lower. But at the same, it is not at par with, say, you know, a Max or an Apollo. It
Right.
would be lower. It would be more like a general, but definitely more than a government college.
Government hospital. Okay.
So, because there's, besides the doctor, I mean, if you see in a running of a hospital, there's one person who's in direct patient care. There are 20 others supporting that doctor to look. And it is only his income to the hospital which has to pay for all those 20 people.
Right. Okay.
Yeah, thank you. Ma'am, I'm joined by my colleagues in Bombay as well. So Pallavi, go ahead.
Hi, can you hear me?
Yes,
Hi,
Pallavi.
Yeah, hi, ma'am. I wanted to ask you a couple of questions. One question is about in the planning, there was plan to talk to East European universities for students returning from Ukraine, which also included universities in Russia to accommodate Indian students. So I wanted to know what is the status of that? Have those universities responded, and are they willing to accommodate?
Yes, we have not yet reached out to them, because we would reach out to them as option 2. Option 1 is students. We have talked to students now, and they would rather, because they're in touch with their teachers, they're in touch with their deans, and whenever this opens up, they would rather go back to their own university. There's a comfort zone. They've learned the local language and they feel very comfortable, and they said that we would like to. In fact, the Chinese students have given an application to the minister and have come and met me, and they are very keen that they be allowed to go back to China at the earliest, because they would want to continue with the system that the curriculum is vastly different. The 6-year course, I have the entire, because we've sort of looked at the analysis of this thing, and I have the complete syllabus here of the semester wise of Ukraine. I have similarly of China, and to be able to, you can't get an equivalence, because the way it's taught, it's very, very different. For example, in Ukraine, the first year that they are spending most of their term learning everything other than medicine. The first term is completely spent in learning Latin, Ukraine language, foreign language, medical chemistry. Then they are learning a little bit of hygiene and something about biological and bioorganic chemistry. Now, these are nowhere there in our curriculum. So, I mean, we can't find this equivalence in our system. So therefore, they would rather go back, complete it, add to that knowledge by getting a little clinical in knowledge, and see our preventive medicine, our disease patterns. You ask them, they're never taught malaria, dengue, and leptospirosis, which is sort of bread and butter, and tuberculosis in Indian colleges.
Yes,
So
yes.
they have to learn about these things.
Yes, and for the follow-up question to it, ma'am, is how many MUHs had asked these students to reach out to MUHs, write to MUHs about their plans? So how many students have reached out until now?
Yeah, so our registration on our website, I mean, I don't know as of today, but before the weekend, so I've told them put me at the end of the week. So I don't know how many more at, but we had about 300-400 children who had registered. But besides that, we've done 2 more things now. I've had yesterday a video conference with 42 of our medical college deans located all over Maharashtra. And I've requested them to let it be known in their local areas that if children have not uploaded, they can even report to their colleges. We've done that. We've also, the ministers also instructed secretaries to tell corporators, and this, so even that data, even if they were registered with us, that data is also now coming to our registrar. So we hope to have the complete picture by then. And we plan to start writing to the, we've now collected all the emails of the universities. We tried sending a few emails. They're not yet responding. And some of the students said that they're having problems over there. They're not yet ready for it. So we thought by, we'll get these people this thing, and then April, we'll start communicating with them as to what is their plan for their students and how we can facilitate learning.
Okay. Thank you.
Thank you. Manoj More?
Yeah. Good afternoon, ma'am.
Good afternoon.
I just wanted to ask you about COVID, because nobody's asking you about COVID. I just wanted to ask you, your view about the way our medical fraternity handled COVID patients, because as a lay person, as a non-medical person, I found, the doctors were thoroughly confused, and their confusion was confounded by central government, by ISMR, which kept giving different directives. Once they said that plasma should be used, then the next directives came, plasma should not be used. Then again, the third directive came saying plasma should be used. It happened with remdesivir also. Remdesivir should be used, remdesivir should not be used. And in the end, what happened was the doctors ended up giving overdose of medicines and many patients died. I have observed this very closely. So just wanted your view on this.
Yeah, I understand this thing, and your observations are quite correct. But having said that, the world was confused. It's not just us. In fact, we were probably a little better off, and I repeatedly, in fact, in the STIAC, I said as to why. And if you see, our mortality figures were much lower in spite of all the chaos and confusion. Why did that happen? And I think there were two main important reasons. One, the waves came much earlier in the USA and Europe and, Italy and these places where we learned by their mistakes. We found, for a simple example, they were doing elective ventilation. We realized that patients were actually worsening with lung trauma. So our protocols changed, learning from them. We did not do that. And in our second wave, we learned the art of non-invasive ventilation. So I think this was something which was totally new. And look at the thing that within a year of first, no one had ever heard of COVID, corona, this thing. By the end of the year, even school kids were talking of RT-PCR, hand sanitization, and SMS. I think it was a huge learning curve. And doctors were no different, because it was not that, you knew everything. You had the tools that if this happens, you do. But those tools did not work. When it came to bringing guidelines, it was such a rapidly evolving situation. There was a race for publishing. Where I saw something, everyone wanted to publish it. When you make a guideline, you have to get through the evidence and then say, okay, let's do this. But when we get our own evidence, we have to change it. Now, this confused at the grassroots levels, because I'll tell you two big problems which were there. And I've again analyzed this and told the government. We were expecting the doctors to be clinicians, to be paramedics, to be data entry operators, to be able to be communicating. Where was society helping? This was different in the armed forces. I think that was again where we were different. When we went into the second wave and were asked to this, I went and told the chiefs, I said, normally when y'all are up front in a war, we are your shoulders. Today, y'all have to be our shoulders. We are the soldiers. And the three services, they gave us battlefield, normal troops, the communication was handled by signals, the dental, the RVC, all people came together and helped us in the hospitals. This didn't happen in this protocolized fashion in the civil street. We could have pulled in for doing, doctor, leave him to just look at the patient. But he was supposed to handle the dead bodies. He was supposed to handle the communication. Where were the systems? So this is where I think we learned a lot. And when all of them started coming together, we did much better.
Ma'am, this is very relevant, because what Manoj has asked about COVID, because you have been part of the national level COVID modeling studies with the IIT people, and they have made a lot of predictions. But ma'am, recently the Lancet has also said a lot of things about the mortality data and about the number of infections like being threefold. So are we kind of missing somewhere, you know, the kind of numbers?
We may have missed some of them, but I think Lancet also has painted a very bleak picture. And there is, leave alone Lancet, there were some editorials even earlier, and for that matter, New York Times, they really predicted doomsday. Absolutely. And then when it didn't happen in the Indian Sutra model, we said, no, we're not going to hit that. And this thing, everyone just kept quiet. Because finally, you know, it's not easy to accept an emerging country being able to vaccinate such large number of people. So you have to keep finding, you know, these things. We may not be the best, but we are definitely not bad.
Absolutely. Ma'am, so many questions are coming up, so I think I better just squeeze in everybody. Rupsa, go ahead.
Yeah, you can go a rapid fire round. One question.
Yeah, so ma'am, I'm Rupsha Chakravarti. I have just 2-3 questions. Okay. So recently, NMC declared that they will allow students to continue with their internship in India. To do that, they have to sit for apply for the FMGE examination, right? Now, the final year students, they were supposed to complete their examination in May and get their degree. Now there is speculation because of the war, and they are not sure if they will get the degree to sit for this screening test. So there is too much confusion among students whether they will have the degree and if that will qualify them to apply for the screening examination to continue with their internship or so. So ma'am, if you could provide some clarification if the requirement of having a degree for the screening test will be waived off for this purpose?
That cannot be said. Yes, I'm in touch with the NMC and we are discussing the way forward for that. But probably we would have to, that is why the importance of being in touch with the universities and them, because someone who's taught them has to say they've completed their education. Someone has to say that they've completed their education. And if this just doesn't happen, we may sort of open, and by next year, this is going to take some time, and I think we are coming up with the next exam next year. So since next exam would be assessing even foreign medical graduates along with our Indian with the same paper, the same standards, the same practicals, I'm sure that by then we can find a solution of how to, suppose they could not, but even if they get a thing that they've finished their training, let them appear for the next exam. They would, once that happens, we would anyway not have an FMGE.
Okay. So academic certificate can be considered in future.
I mean, this is one of the hypothetical. I can't be dogmatic and say, yes, we can. But when we look at the problem at that point of time, we can think of it that in these circumstances, if they get a certificate that they've completed their training, can we make them, let them appear for our next exam?
Okay. Ma'am, my second question is about the Malegaon test that you are doing. So what is the update on it? Like, have we come to a conclusion?
Yes, it's going extremely well. We have completed the 2,600 samples. They've all been assayed. The antibody levels are being uploaded on our website, and we have a statistician even this thing. Just last week I've done a review, and we are going to now start collecting the second samples. They were due in April, but April we found out they're going to have Rosa, and then they would have Ramzan and this thing, so we might have to delay it to May. So 10th May is projected date.
This was one question which I wanted to ask, but just to add to Rupsa's question, ma'am, what is it about Malegaon that they did not see COVID cases? I mean, they had it in the first wave, but in the second and the third wave, kuch bhi nahi tha. Kyun?
Yeah, so that is exactly why we are trying to find the scientific evidence. Okay. And with that, we've done an extremely, and it's, I think, the first time in India where administration, health authorities, and all pathies have worked together. I had 162 healthcare people working in the field, and in 8 days collecting 2,700 plus samples. I mean, it was some kind of and done in the most systematic. You can go even now, the house from which the sample was collected is marked because they were told consent taken from them in Urdu, in every language, and from Asha worker to local corporator to healthcare workers. They made teams, they went into the community. So this was a true thing of a community research undertaken by the university.
So ma'am, during the research, did you find any kind of hurdles, like any kind of obstruction or any?
Initial, there was a lot of skepticism, and the Unani college, which is located in Malegaon, they told us, so we did it very scientifically. When this idea came, when the municipal commissioner called on me and he said, I'm wondering why this is happening. I said, I'll give you a scientific answer, but you have to give me time and I'll design a proper study. So when we this thing, I call stakeholders, they said, ma'am, log khoon dene nahi aayenge. So I said, okay, if that be the case, we have to address the community and reassure them why we are doing this. So to do that, before we started the study, the municipal commissioner, myself, we went there, the local mayor, she came in, the corporators came together, the Maulvis came together, we addressed them and answered all their queries. Then they were so convinced, they went out and we didn't have to, people came and said, le lo hamara. So that is where we won.
Thanks,
can I ask one more question?
Rupsa, I'll get you in because
okay.
it's some people who have not asked a question.
Sure.
Sushant Alifia is there. But let me ask Anjali to ask a question since she's not asked one question. Anjali, please go ahead.
Good afternoon, ma'am. All of them spoke about students and doctors. My question is, what about nurses and the paramedics? Many of them, I understand that the courses for nursing is equally expensive. And it's a trend that many nurses, they start their practice or they start getting employed in India, but they soon move abroad. How do you see at this situation and what can be done to improve the support staff for the medical team? Thank you.
Yes, I totally agree. I mean, the girls who go for nursing, a lot of them come from a lower socioeconomic background. They really need support. They're very hardworking and excellent girls who come forward for training. But we do not have adequate nursing colleges, and more important, again, the quality. Because as against medical colleges where we can train 150, 300, nursing colleges, they averagely 50, 60, they're smaller numbers because there's a lot of hands-on and skilling that it requires to be trained for them. And it's very, very tutor heavy as per their syllabus and curriculum. So that is where the problem is. And secondly, the dedication and sincerity with which our girls are, once they are trained, obviously the world wants them and they can pay them better. So that you can't stop them. In fact, I will tell you, the lowest fees, people ask this thing, you would be surprised to know that today, the lowest fee is in All India Institute of Medical Sciences, Delhi. And that's the college where the top brains go, because they take only 50 or 60 students and majority go off abroad. So where is the system which says that if the government is and the country is spending on that education, shouldn't they be serving?
That's true. On the same lines, I think Sushant wants to ask a question on women in the armed forces. Sushant, please go ahead.
Ma'am, from the era where women were only limited or mainly limited to the medical services in the armed forces, we have come a long way. Women are serving right from the fighter pilot stream to, they are also now receiving permanent commission. What is the way ahead? How should this be taken further? And what are the where should be the care taken in this area?
Yeah, two things. Firstly, medical means includes nursing, because the nursing services took women even before the medical services. So that's one fact. Secondly, women, yes, they are coming in larger numbers in all the three forces, and they're also joining at, why do we talk only at officer level? Today, the military police, the Assam Rifles, they've taken them even at the so combatant level, soldiers level. So I think that is a way forward, and it reflects the progress of society. It is not just about women doing it, it's about society and the organization accepting them. As far as using, I think too much time and energy spent on saying both are equal. I've never understood why both have to be equal. I mean, if there are some jobs which need strength, physical strength, and this, so let who's the, people who are doing that. There are lots of jobs in the armed forces which don't need that kind of rigorous to be at Siachen or this. And you could utilize them in those services to begin with, let them continue with permanent commission and other these things also. If the women are ready and the society is letting them join, then after that, don't look at them as women, look at them as soldiers, look at them as officers. There's no gender then. And that is possible only when the organization also starts. It's just logistics, basic things of privacy or toilets or this, those have to be, they're all administrative these things. Those can be, if those are handled, the rest I think will fall in place, and women would be able to serve anywhere and do any kind of a job.
Thanks, Sushant. Alifia, you can go ahead. I think we have time for one or two more questions.
Ma'am, recently the NMC had passed this guideline, which was later confirmed by Prime Minister Modi, who tweeted a few days ago that 50% of the seats in private medical colleges, the fees will be on par with those of government medical colleges. And while this is a great move for affordable medical education, what does it reflect on the other 50%? Will it push the other 50% to pay much higher fees? And a few private medical colleges actually have recently written that they be allowed to enhance the existing capacity, so that they can bring some kind of rationalization to this cost. So what are your views on that?
Yeah, I think it would have to be taken in a holistic way, because even the government has a range. It ranges from 1.5 lakhs to 5 to 6 lakhs a year in different states. So firstly, they would have to find a common listing of what is this government rate. And if 50% have to be there, they would, I'm sure, have calculated out what would be. And there are fee regulating authorities, the FRA, which looks into all these feasibilities. And in case it is there, I think one way of subsidizing is what states are now doing, by letting people who do a subsidized education, either their state loans or they're waived off, for which you serve for 3 years, 5 years, the whole, like the armed forces works, we all serve, once we do AFMC training, we all have a compulsory this thing, or we pay the cost of training. So you have a choice. So it will then be equitable, even if I can't afford it. If I have the merit, I have the capability, I can do it. It doesn't matter what the fee is, and I can give it back by working for a few years in that. So I think that's a model which is possible.
But ma'am, there is also the issue of reservations, because All India quota, OBC, Maratha, etc., etc. So in all this space, really the general merit category student eventually loses out. Yeah. So which is why we see this exodus to Ukraine and Russia and all that.
Yeah. But those are, government and political decisions. And right. That I don't think us talking or debating will make no difference. So that, and I'm sure they look at all aspects and perspectives when they, take those decisions. But if you just have, at one point of time, the country was flooded with so many engineering seats, colleges shut down.
Absolutely.
So it is also what lies after that. When we open up, we have to look at career options after that. Medicine people is attractive because even if you don't get a job, you can sit somewhere and start working and feed yourself. So that is the biggest attraction of medicine. So I think that is where, if we have a structure, which we are now looking at, through wellness centers, the Maharashtra government, they've just taken out some new things that even at periphery, they're going to give higher amounts for people with more training and in remoter locations. So I guess it will have to be a supply and demand. And make it attractive. Make it attractive so people come and work.
Amita, we have time for 1 or 2 questions.
Yeah, sure. I think Rupska had one.
So is Ruchika
yeah,
there?
We have about 5 minutes left, so we will hurry.
Ruchika, you please go ahead with your question, and then I'll just wrap up and ask ma'am one question which I've been wanting to ask. Ruchika, go ahead. Is she there? Okay, ma'am, I think I don't know where she is. So,
as she says, I don't have one.
Ruchika, I just saw a question. Roopsa had.
Okay. So,
Pallavi.
Pallavi or Roopsa, one of you all have a question, so please go ahead.
Shall I?
Yeah, go ahead.
Yeah. So, ma'am, as we said, there are many shortages of faculty members, right? So, for the past 45, actually more than 45 days, these doctors are on protest about their salaries not being up to the 7th pay commission, and they're not provided the sanctioned doctor post. So my question is that why these contractual doctors are not being hired on a permanent basis, which will help us to fill up the blank post in the government medical colleges?
I think they've given this thing of, that deans can even hire and take people on contractual permanent, and this thing, those are, I guess, administrative issues which the administration is looking into. There must be rules and regulations, about when you recruit, there are different rules. When you take a temporary, even in the university, I've got so many contractual people who would like to become permanent. But I have rules bound and I must follow those. And so therefore I've told them that, yes, now in our next recruitment, please all of you all apply and go through the process. So that I think that's a way forward.
Ma'am, as the VC of MUHS.
Who's this? Sorry. Pallavi.
Okay. Yeah, Pallavi just asked, then I'll just
wrap it up. Thank you so much. Ma'am, I wanted to ask you about what happened with the microbiology paper in the MBBS examination. The decision that you took, though, was a tough one, was fair one. I wanted to understand if certain measures are being taken that these are the kind of things do not repeat in future.
No, there was an incident which happened where the match was too close in one of the colleges between a prelim paper and that submitted to the university, and it happened, and in that the paper was too so exact that there was no leak as such, but it had been used by the college for an internal assessment. Once that was brought to my notice, I have to make it transparent and equitable. I mean, even those students didn't know that it's the same paper, and they've been coming to me saying that why are you punishing us? So I said, it's not punishing. So just for your information, I said, okay, let me see, because the people who won the exam must be feeling that we did badly and we did not know it, and others have got to know the paper. So I will do a democratic thing, and I did a Google a form which was responded to by all 6,000 plus students, and 13% said, ma'am, we want a re-examination.
Okay.
So
Thanks. Any new measures are being taken to, so that this is not repeated in future?
Yes, absolutely. So that would be, we have our rules, administrative, there's a committee which has been this thing, and it will be investigated. And so that, and also we are trying to change the computerized system of jumbling up, because we do take 8 papers. 8 papers are there, 8 are moderated, and then they're all kept sealed, and final which goes, even the controller of examiner doesn't know. So when this was brought to my notice and I asked him, he says, ma'am, it's a Saturday, but I'll open up the department and I'll pull out to see, and then he had to get the prelim paper faxed to him, and then we had a board of examiners urgent meeting and quick decisions taken.
Okay. Thank you so much.
Thanks, Pallavi. Ma'am, just to wrap it up, I guess as the VC of MUHS, you had said that you're going to prepare a vision document and the roadmap ahead, and rural health is also of concern. Plus, so what are the key takeaways that you have in this vision document apart from standardizing medical education? So, and
this vision document is different, and I'd request all of you all to go onto the MUHS website. It's so, a transparent and honest effort that I've even uploaded it to say, what do I intend to do over the next 4 years? And it's not just a wish list, it is timelines and deliverables and how do I plan to go about it. And I'm extremely happy that the first 4 months I've achieved 100% of everything that I put down there. And just on 22nd, I have the Senate meeting and I was preparing, taking stock of the situation, and the entire team here said, ma'am, we've never, we've all feel so satisfied that so much has got done. So I think it's thanks to a wonderful team here who is probably losing sleep working with me. My engineering head told me he's lost 4 kgs, but they're all smiling.
Is a defense attitude. Thank you so much, ma'am. And Amitabh, you would like to say something?
Yeah, thank you so much for taking time out. I think it was very, very useful. I am sure Anuradha would continue to remain in touch with you for all sorts of information. Thanks a lot. Thank you.
Thank you,
everyone.
It's been a pleasure for me as well. Thanks a lot, everyone, and have a great evening. Bye-bye.